For those of you who are not familiar with EPI-WIN, it stands for the WHO Information Network for Epidemics. So it's our way of science translation in public health emergencies, making science, our goal is to make science accessible, understandable, and relevant so that we have more evidence-informed actions and policies during public health emergencies. Today's webinar is very topical for many of us who've been suffering from flu. It's the current global influenza outbreak, what we are doing and what it means for pandemic influenza. We have very eminent global experts today speaking, but before I go to that, just a few housekeeping issues. Please, I request all participants to introduce yourself in the chat with your name, what you do, and which country you come from. It would be great to know you. The second point I'd like to tell you is that if you can put your questions in the Q&A, we'll try and answer as much of that as possible. And you are being recorded. This webinar is being recorded, and the recording will be on our website after the webinar, and you can access it whenever you like. So without further ado, I'd like to introduce our speakers today. Making the opening remarks is Dr. Sylvie Briand. She's the Director for the Department of Epidemic and Pandemic Prevention and Preparedness at WHO Health Emergencies. We also have Dr. Wenqing Zhang, who's the Unit Head for the Global Influenza Program in WHO, and Dr. Joshua Mott, who's the Senior Advisor for Influenza in WHO, and who was also earlier with the US Center for Disease Control and has decades of experience in influenza. And joining us from Hong Kong is Professor David Hui. He's the Stanley Ho Professor for Respiratory Medicine and the chairman of the Department of Medicine and Therapeutics at the Chinese University of Hong Kong. He is based at the Prince of Wales Hospital in Hong Kong, where but there was a SARS outbreak in 2004. And since 2004, he's been an advisor for WHO on the clinical management of emerging severe acute respiratory diseases, including avian influenza, pandemic influenza, MERS, CoV, and of course, COVID. So he is joining us also from Hong Kong to give us the clinical perspective on this disease. At the end of the presentations, we will have Q&A sessions where you can ask questions from all the speakers. I'd also like to introduce a few more colleagues who are in this webinar. Dr. Jubika Latinovic, Technical Officer for Science Translation, Ms. Jiangfang Liu, who's supporting us with the technical side, and Ms. Aspen, Hammond, and Mr. Christopher Chadwick, Technical Officers for Influenza. I'd now like to welcome Dr. Sylvie Briand and I request her to give the opening remarks. Over to you, Sylvie.
Thank you very much, Supriya, for this introduction, and good morning, good evening, or good afternoon to everyone. It's really a pleasure for me to be with you today, and I have to apologize in advance because I'm not in my office. I am in India.
Sylvie has been kind enough to join us even though she's traveling today. She's in India at the moment representing WHO at the G20 summit. So I think therefore the connection. Oh, you're back, Sylvie.
I'm back, I'm sorry. So this is my connection problem. I'm not in the office. I'm in India to attend the G20, but I will very briefly give some remarks so that you can continue with my colleagues who are better connected, hopefully. So First of all, I would like to say that every one of us had flu at least once in our life. For some of us, it was a very mild disease, like a common cold. For others, it was a disease that allows you to stay in bed for a few days. And for some people, it's a very severe disease. I had a miscarriage following flu. Can you hear me now?
Yes. Please go ahead, Sylvie. Okay. We just wait a few seconds. I hope she'll be able to connect back to us. While we're waiting for her to join, we'd like to share a short video clip where she's spoken about influenza in the Science in 5 program, which is where you have a short interview, and it's done by my colleague, Ms. Vismita Gupta-Smith. You can find Science in 5 clips on various topics on our website, and Sylvie had recently spoken on influenza. So we'll just play that video where she spoke about the spike in respiratory diseases recently, and she also explains how the influenza vaccine works.
We are seeing a spike in respiratory viruses, all kinds of viruses, COVID-19, influenza, RSV, and this is not a surprise. We always see an increase in respiratory diseases in wintertime for the northern hemisphere. Why? Firstly, because most of the 175 types of circulating respiratory viruses prefer cold and humid weather. Most of them produce mild disease, but some of them, like COVID-19, influenza, or RSV, can produce severe disease, leading to hospitalization and even death. Secondly, when the weather is cold or humid, people tend to gather indoor in less ventilated spaces, and thus are more exposed to infection. However, this year is a bit special. We are seeing more respiratory disease than usual. We think that this increase is due to at least two factors. In the past 3 years, people were applying personal protective measures like masks, washing hands, less gatherings. But this year, in many countries, most of these preventive measures are not applied anymore. In addition, people have probably lost some of their immunity against respiratory viruses in general, given the low circulation of respiratory viruses in the past years, thanks to the protective measure. There are many influenza viruses circulating. We know at least 3 big families, A, H1N1, A, H3N2, and B viruses. What is important to know is that these viruses evolve constantly. As they multiply in human cells, viruses are changing. This is like having a parent virus, making many children, and then having many grandchildren, and many great-grandchildren. The influenza vaccine, it's like a picture of the virus, a picture of the enemy that is shown to our internal defenses, the antibodies. When the antibodies have seen the picture of the virus, they can recognize it. So when the virus enters the body, the antibody can push it out. This is how the influenza vaccine works. However, because of the constant evolution of the virus, we need to update the influenza vaccine composition regularly so that the picture of the enemy that is shown to the antibodies is not the picture of the parent virus that was circulating last year, but the picture of the great-grandchild viruses that are circulating this year.
So that was a short clip from Sylvie, which was played in Science in 5, produced by Ms. Vismita Gupta-Smith. We will now request Dr. Wenqing Zhang to talk about the current influenza outbreak and give a global overview. Over to Wenqing.
Hello, I hope you can hear me. Okay, I'll continue. I hope you can see my screen. Let me run the screen. Good. So with best wishes for a very happy new year, I'm to give you an overview of the current influenza situation, and I will also talk a little bit about how it is being managed. I hope that my internet connection is fine, is okay, as I'm also in a hotel in London on duty travel for the topic of influenza, of course. Okay, so let's look at the influenza situation in the context historically since 2017. Let me just hide this. Those colorful bars are the influenza viruses detected. But for now, let's look at the red curve here, This is a positive influenza positivity rate from the Sentinel surveillance system. So this curve picturing the influenza virus circulation in community. We can see that during COVID-19, the influenza circulation was extremely low, but towards the end of 2021, influenza returned. And as of the end of 2022, they were already to peak already. So with regards to the current situation here, whether the Northern Hemisphere influenza season already peaked or not, we are yet to see. This map shows the current influenza situation, and we can see many countries in the Northern Hemisphere now are undergoing the obvious influenza season. One exception is in China. Influenza at the moment, circulation is extremely low. So just to summarize that influenza situation since COVID-19, it has returned and it is increasing. In some countries, it's already back to the pre-COVID-19 level. In some countries, even higher than pre-COVID influenza season. And we've also see varying timing, i.e. the starting of the season are different now, and also the severity also varying in many countries. Now let's look at the current influenza season in the context of the co-circulating of respiratory viruses. Here is SARS-CoV-2. This chart shows again the co-circulation or relative co-circulation of SARS-CoV-2 and influenza viruses. Let's look at the very right, the arrow pointed here. This is starting from September, October last year. It's exactly the timingly, the Northern Hemisphere influenza season. And we can see in many countries, the circulation of influenza, which is pictured in blue curve, is higher than the red curve, which is a positivity rate of SARS-CoV-2 virus. Let's zoom into a couple country examples. The upper chart shows an example in the Northern Hemisphere. It is the situation in Germany. And we can see, again, look at the very right side of the curve. We can see that influenza circulation actually is higher as being detected in the Sentinel system in the country than the SARS-CoV-2 virus at the moment. The lower chart shows an example in the Southern Hemisphere. That is a South Africa situation. And this is a very interesting situation as in South Africa, influenza started in in the end of 2021, as we can see here, started here. Then it's dropped. We look at the blue curve because at that time, the Omicron virus arrived, driving the influenza circulation down. Then in April this year, influenza activity started again, and then it had a quite long season. And during this season, influenza virus circulation certainly was higher than the SARS-CoV-2 virus circulation as being monitored through the Sentinel system. So when we are talking about influenza, there are three types of influenza relevant to public health. One is seasonal influenza, we just talked about. Why we talk about seasonal? Because it comes often with the winter season and it recurs. Another type is called zoonotic influenza. That influenza referring to the influenza usually in animal population, but sometimes jumping out to human, to infect human, causing human infection. We've been talking about avian influenza, swine influenza. So these are all zoonotic influenza. And the third is pandemic influenza. Of course, all of us know 1918 as a pandemic, also called so-called Spanish flu, all of us know. In 2009, there was the H1N1 pandemic. And surely there will be a pandemic, a next influenza pandemic, H, X, and Y. There's no question mark there. The only unknown is when. It could be very soon. So let's zoom into the avian influenza situation now. The upper right, the map shows just the number, the dots referring to the report of outbreak of avian influenza in animals. The picture just shows those reported within less than 3 months from October to December. To FAO and OIE now is called OR. Let me give you some numbers of the outbreaks in animals. It's really very shocking. In 2018, there were around 750. And in 2019, in the calendar year, 320. In 2020, it's around 1,600. In year 2021, it's 3,800. And in 2022, last year, it's 6,800. So the increasing number of outbreaks reported in animals is really shocking. And also we've seen the unprecedented reassortment of avian influenza viruses going on and the genetic diversities in animal viruses or in avian viruses. Now let's look at the human side. Human infection of zoonotic influenza or avian influenza never stopped throughout the COVID-19, although seasonal influenza circulation was extremely low. During the COVID, the first human infection of avian influenza H3N8 and H10N3 were reported from China, and the first human infection with avian influenza subtype H5N1 were reported from Russia. UK and US reported for the first time human infection of H5N1 subtype. And probably many of you know that in the past few weeks, just before a few weeks ago, the first case of human infection with avian influenza H5N1 was reported from Ecuador. And this is the first report from South America. So all these sending off an alarming message of the influenza pandemic. So let's talk a little bit about how influenza is being managed. We do not need to be panicked though, because influenza is an old enemy for public health, and it's being managed for dozens of years by a global system called Global Influenza Surveillance and Response System, GIS. Last year, this system celebrates its 70th anniversary, and many of you connected in this webinar in your countries, there's members. They are members of the global system. It's called the National Influenza Centers. So this system has institutionalized and functioning capacity in your countries with laboratory disease surveillance going on, with response mechanisms exercised every season in epidemics, and with enormous commitment from countries also. This is the same system being leveraged and used for COVID-19 pandemic response. So for seasonal influenza, it's being managed year-round and remanaged year-round from end to end, from specimens to the final product, i.e. vaccines. Just to make our point here is about the genomic surveillance, which I think the terminology now is known by everyone in the world. Just to point out, genomic surveillance is one component of the GISRA surveillance. And for influenza, genomic surveillance started in 1980s to support influenza surveillance and response, of course, at the scale, not as today's, the accessibility to the technology, etc. nowadays, thanks to the COVID-19 pandemic response. With regards to managing the zoonotic pandemic influenza, it is a live example of collaborative surveillance with different systems, mechanisms working together complementary to manage the outbreak. Just to highlight a few keywords here, influenza management is year-round operation. So the capacity, capability, etc. is live. And it is collectively and globally in order to be successful, because influenza virus circulating is respiratory viruses circulating without boundaries. And the key words of in order to be successful, one is timeliness and the other is representativeness. It is not really the number, the absolute number itself. So to get ready for the next influenza pandemic, WHO is working intensively with its member states, with partners from animal sectors, from public health sectors, from private and public sectors, etc. Looking into every details of the preparedness, we look into preparedness of those that could be prepared now through the seasonal influenza management, through the zoonotic outbreak management. We're also looking into those that could only be managed when the next pandemic virus emerges. So at the moment, we are looking into experience learned from COVID-19 to equip those, to absorb those into the influenza pandemic preparedness, and also to look at the new technologies, not only the diagnostics, but also the new products development, so that next influenza pandemic response can be benefited. Let's take 1 minute's glimpse into those beyond influenza. And this is from GISRAS. This is a global system, GISRAS to GISRAS Plus. So the global system GISRAS was established in 1952 for seasonal influenza. And since 1997, with the emergence of highly pathogenic avian influenza H5N1, the avian influenza, variant swine influenza, and in 2009, pandemic influenza are being added to the surveillance platform. So these are different types of influenza. For each type of this influenza, there are different genetic clades of that. So genetic clades in SARS-CoV-2 is also called variants. So for each of these type of influenza, there are different variants, or if we're using the terminology of SARS-CoV-2. In 2015, RSV, respiratory syncytial virus, was added into the surveillance platform, and since March 2020, SARS-CoV-2, COVID virus, was also added into the platform. So from now on, what is this global network comprising 158 institutions in 127 countries? So the whole system are on board to use, to strengthen, and to expand its scope beyond influenza using its asset. Some are visible, for example, infrastructure and workforce, which were used for COVID-19 pandemic. Some are invisible, that's the trust and confidence of the system. and to conduct the collaborative surveillance with entities, with agencies to complementary conduct surveillance in different stages to meet the specific public health objects. I think that's all from my side, just to acknowledge my colleague in the Global Influenza Program and my colleagues in countries, in 127 countries and more were contributing to the global influenza surveillance and response. Thank you very much, and back to Supriya.
Thank you very much, Wenqing, for that comprehensive overview of the current situation, how we got there, and of course the very important flagging of the risk of pandemic influenza, now that we also have a new case of H5N1 from Ecuador and the animal influenza cases in humans, and the importance of surveillance of new products and others to manage the current influenza outbreak. We'd like to now, from the global level, go to the country level and request Dr. Josh Mott to give us an overview from what's being done in the US perspective on the influenza outbreak. Over to you, Josh.
Thank you. I'm sharing my screen now and try to. I hope that this can be seen and that I can be heard. I want to give you very quickly, as you saw in the Northern Hemisphere, the United States is now experiencing its own significant influenza season. And I wanted to talk to you a little bit about priorities in the United States and current initiatives as we prepare to monitor influenza and indeed other respiratory viruses moving forward after all the lessons learned of this pandemic as well. So the CDC Influenza Division works toward the prevention of seasonal and novel influenza virus infections in humans and to reduce morbidity and mortality associated with them. And as I hope to show you, all of that work on an ongoing basis improves influenza pandemic preparedness in the country as well. They're all interrelated. In collaboration with domestic and global partners, the CDC Influenza Division in the United States works to build surveillance and response capacity for influenza, monitors and assesses influenza viruses and illness, improves vaccines and other interventions, and applies research to provide science-based enhancement of prevention and control programs. There's a lot of opportunities and challenges in the area of surveillance that have come out of the COVID-19 pandemic, and it prompted rapid and necessary changes to surveillance. It created, as you saw from Dr. Wenqing's presentation, an unpredictability, of influenza seasonality that required our surveillance systems to take a hard look at where influenza was and was not circulating. It affected our interpretation of our systems.
Sorry, Josh, sorry to interrupt. Could you put your slides on presentation mode? It's still...
Sure.
Thanks.
Let me try to do that.
On a big screen.
Let's see.
Sorry for my technical limitations. Let's see.
Do you want us to?
I'm looking for this button for presentation mode.
Josh, can you see display settings up top?
I can. I see remote control.
There. Now look at display settings. Can you see that? Yeah, and switch. Yep.
Got
Perfect. Got it.
Okay. Sorry about that. Okay. It affected the way that we interpret our syndromic surveillance systems like ILI and SARI, because now there is another important contributor circulating endemically in COVID-19 to these systems. There were changes in healthcare seeking behavior in the United States and globally that our systems had to adapt to. And we've simultaneously been dealing with the emergence of avian influenza H5 throughout the country that I'll talk about, and that Dr. Wenqing had mentioned. This has produced important opportunities to modernize our data systems in terms of new and diverse data types, the speed and accuracy with which national stakeholders have access to state-based information, and integrating and visualizing the current epidemic. And this all helps us prepare for seasonal influenza epidemics as well as the next pandemic. So globally, influenza seasonally is important for a large number of deaths, anywhere from 300,000 to 700,000 annually, and many more severe cases and infections globally. And I use this slide because I want to show that each and every year, influenza seasonal epidemics exact an important toll. For example, on this slide from the United States, you can see the blue line of the 2017-18 influenza epidemic season, which was a particularly bad season. And these are the outpatient consultation rates in the United States. And you can compare that to the last influenza pandemic in 2009, which was quite comparable. So each and every year, there's an important burden of morbidity and mortality in the United States that I'll tell you more about that needs to be prevented and reduced for seasonal influenza. To do this, the United States puts together its epidemiologic surveillance from multiple sources. Layered surveillance feeds into weekly public health reports and interactive data at the national level through the CDC. Mortality data, hospitalization data, all from different systems, outpatient and emergency department data, and data on virus surveillance, and even data from the community are fed into health departments and into the US CDC for interpretation. This expansion was initiated for the 2021 season, and it's served to support the monitoring of COVID-19 as well through the pandemic. One way to think about it is if you look at the burden of influenza, we have different systems that are put together to monitor mortality, to monitor hospitalizations in selected locations, and to monitor outpatient visits. But the burden of influenza extends beyond that. And we also have to combine that with special studies to understand details of etiology and the effectiveness of treatments, to monitor vaccine effectiveness used through VE networks, and of course, cohorts and sero studies that are going on an ongoing basis to look at symptomatic illness and those infected in the population. So it's a mosaic, if you will, of special studies and surveillance systems that are put together in the United States every year to understand the burden of influenza. In the current season, this is the virologic surveillance for the current influenza season, and you can see that it rose steadily. Influenza circulation through week 48 of 2022 and has started to decline since then, with both H3N2 and H1N1 PDM09 co-circulating. And we have to see, normally the influenza season in the United States extends into the spring in the following year, and we'll have to see what 2023 brings. But that collaborative set of surveillance systems that I was showing you in studies allows us to assess the burden each and every year. And so for the current season in the United States, we've seen an estimated 22 to 43 million flu illnesses, 10 to 20 million medical visits, anywhere from 230 to 490,000 hospitalizations, and a minimum of 14,000, but up to 43,000 influenza deaths in this season alone. So influenza is certainly back circulating and exerting an important burden on the population. This set of systems brought together allows us to say certain things each and every year in the United States about influenza season. And so for the current season, it tells us that seasonal influenza activity remains high, but it is continuing to decline in most areas. Of the flu A viruses detected and subtyped as of week 52, 70% were influenza H3N2 and 30% H1N1. We've estimated that so far this season, there have been at least 22 million illnesses, 230,000 hospitalizations, and 14,000 deaths from influenza. And the cumulative hospitalization rate in our hospitalization system has been 3.5 times higher than the highest cumulative in-season hospitalization rate for the same time during previous seasons going back to 2010 to 12. However, as I mentioned, influenza seasons extend into the spring, and it's still lower than the end of season hospitalization rates for all but 4 pre-COVID seasons going back to 2010-11. So we have to see what the rest of the season brings in order to assess the overall impact and severity of the season. The majority of influenza viruses tested are the same genetic subclade and antigenically similar to the influenza viruses included in this season's influenza vaccine. And all the viruses collected and evaluated this season have been susceptible to influenza antivirals oseltamivir, peramivir, zanamivir, and baloxavir. The reason we can do this in the United States comes from a strong laboratory network. There's 1 million patient specimens that come in from clinical labs participating in domestic disease surveillance, another 100,000 that come into public health laboratories. Of these, CDC conducts a full genetic sequencing on about 7,000 flu viruses each year, with 2,000 undergoing a different evaluation of immune properties. And then as many as 50 are shared for possible use in vaccine production. This laboratory network allows us to produce diagnostic kits, I'll talk more about, supports the availability of viruses for next generation sequencing and for phenotypic, antigenic, and antiviral sensitivity evaluations, and to develop candidate vaccine viruses for both egg and cell-based inactivated vaccines and for live attenuated vaccines. This laboratory science was very important to leverage during the COVID-19 pandemic. In particular, the influenza SARS-CoV-2 multiplex assay that has been disseminated globally grew out of the technologies in place from this lab network. And there's a focus now on increasing national and international sequencing capacities with an expansion of US national reference centers happening, and partnering closely with the Global Influenza Program at WHO on the expansion of international sequencing hubs globally. Continuing, very importantly, the US continues to explore new and innovative laboratory technologies related to targeted genetic evaluations and modifications in those diagnostics, assessing genome sequences in travelers to look at how things are moving and changing globally, and getting more support and getting ready for messenger RNA vaccine platforms as well. This technology is brought to bear because the US CDC is, of course, a WHO collaborating center for reference and research on influenza and part of the global influenza surveillance and response system. And so it lends its resources to the global work that Dr. Wenqing's Global Influenza Program leads. An important part of doing that is through the CDC's international reagent resource. In 2021, $2 million worth of PCR assays were deployed to international laboratories supporting surveillance, and over 2,500 of those previously mentioned multiplex kits were provided to 138 countries as part of the global influenza surveillance and response system. Focusing on vaccines is another important priority in the United States. We know that there's an annually reduced burden of disease, but developing the influenza vaccine system maintains the health and the strength of the actual health system in terms of cold chains, trained staff, cost savings, and integration. And it helps to be better prepared for future pandemics by keeping systems for delivery, regulatory pathways, and operational capacity, and even the awareness of vaccines in the population exercised to be ready for the next pandemic. As I mentioned, influenza vaccine, even the current influenza vaccines play an important role in reducing the burden of illness in the United States. We've estimated that about 85,000 hospitalizations are prevented, 2.6 million clinic visits prevented, and 5.3 million infections prevented in the United States by influenza vaccine at its current effectiveness levels each and every year. That doesn't mean these vaccines can't and shouldn't be improved, and it's an important direction that's being taken in the United States is to build off the WHO preferred product characteristics and the global influenza strategy to move toward better tools to improve and leverage the new technologies in vaccine that have also come out of the current pandemic. There's a global roadmap for influenza vaccine research and development that CDC participates in with WHO. And that's working on 24 strategic goals and many milestones to improve vaccines over time and make them available to the population. That can be improved vaccine characteristics that are incrementally better than the current ones that we have, with an ultimate goal of perhaps moving toward a universal vaccine that needs to be updated far less frequently than the current vaccines that we use. And there's a 10-year plan for prioritizing and coordinating global influenza vaccine research and development that CDC as part of WHO contributes to. Sorry, going the wrong direction here. Okay.
Josh, could you try wrapping up now?
I will try
in the
to wrap
interest
up.
of time.
Yes. So I'm going to wrap up by talking quickly about novel influenza. Dr. Wenqing showed that due to the both increased surveillance, but also the connectivity and convergence of populations in the world, there's a greater pandemic threat associated with novel influenza than there ever has been before. This is manifest in the United States H5 situation, where we've seen over H5 detected in over 5,800 wild birds and 58 million poultry. H5 has been detected in every state, and almost every state has had poultry outbreaks. So far, there's only been one reported human infection with H5 in the United States. The assessment of that is we've produced many candidate vaccine viruses over the years. And the one for this H5 virus is nearly genetically identical to the 2022 viruses that are currently circulating in wild birds and poultry in the United States, and the virus in the person that tested positive in the United States. This candidate vaccine virus has been shared with other vaccine manufacturers. We're continually analyzing at CDC newly available vaccine data. We haven't seen any concerning mutations or genetic markers identified based on previous associations with greater disease or transmissibility. Similarly, the antiviral analyses indicates that currently approved influenza antiviral treatments in the US would be effective against more than 99% of these H5 viruses. This has forced us to exercise our data systems and monitor both poultry and human infections in the United States, allowing our data systems to be monitored in terms of the way CDC works with state health departments. And it's an example, again, of how we've leveraged, and there's all of these systems that were leveraged to do the same during the COVID-19 pandemic and inform the pandemic response in the United States as well. So with that, I'm going to conclude and say that epidemic influenza has indeed returned and exacts an important burden of disease every year in the United States. But pandemic influenza remains as important a threat globally as it's ever been. The capacities that support the monitoring, prevention, and control of seasonal and novel flu enhance pandemic respiratory disease preparedness as well, and response capacities. I know that's a lot in a short amount of time. Happy to take questions, and thank you very much.
Thanks very much, Josh, for that very comprehensive overview of how the US is tackling the influenza outbreak. I'd now like to request Professor David Hu, who's had years of clinical experience in influenza and other respiratory diseases, to talk about, give the clinical perspective. Over to you, Professor Hu.
Thank you, Supriya. Okay, so in this talk, I'm going to briefly compare clinical symptoms spectrum and the viral kinetics and transmission between the two infections. And I will also cover the diagnostic test, drug treatment, and at the end, influenza vaccination. Now, the transmission routes between the two infections are actually quite similar, mainly through inhalation of respiratory droplets. But in environments that has poor airflow, short-range airborne transmission can also occur. And of course, contact with fomite is another route of transmission. The spectrum of influenza and also COVID-19 are also a bit similar, but different in the statistics. So for COVID-19, the majority of cases, up to 80%, mild to asymptomatic. About 14% require hospital treatment because of severe disease, respiratory failure. About 6% require ICU care. And currently, the global mortality is about 1%. For pandemic H1N1, the case fatality rate is between 0.15 to 0.25. And the great majority actually have mild to asymptomatic disease. This is the viral kinetic data. On the right-hand side, you can see the nasal swab and throat swab and combined nasal and throat swab RNA data. And you can see the viral load peak on about day 4 and then gradually decline. Influenza is quite similar, peaking earlier on about day 2 and then decline. So the viral nucleic acid shedding pattern of patients with SARS-CoV-2 resembles that of a patient with influenza. So as a result of the early peaking of both infections can actually cause a lot of community outbreaks because of the early peaking of the viral load. But when we compare the two infections, the incubation period is shorter with seasonal influenza compared to SARS-CoV-2. Even now with the Omicron variant, the incubation period is still about 3 days. But for influenza virus, it is about 1.4, a median. The serial interval, that is the time between successive cases in a chain of transmission, is also shorter for influenza compared to SARS-CoV-2. The basic reproduction number, that is one case can infect how many cases, is much higher in SARS-CoV-2 compared to seasonal flu. And of course, we can prevent flu infection with annual influenza vaccines, but for SARS-CoV-2, now we require booster doses. For secondary prevention, we can also rely on oseltamivir or baloxavir. The symptoms of uncomplicated illness is actually quite similar between the two infections, mainly with upper respiratory tract symptoms with some systemic symptoms like fever, chills, rigor, myalgia. However, the disturbance of taste, like the hypogeusia or ageusia, conjunctivitis, chilblain-like lesions of hands and toes are more specific for SARS-CoV-2. So these are the symptoms which can occur in both conditions, and the complications can also occur in both conditions. And it is hard to say one is more common than the others. Now, when we try to differentiate between the two infections, nowadays, of course, we rely on multiplex PCR that can detect influenza A, B, and SARS-CoV-2. And often we may take nasopharyngeal throat swab, or we can also combine nasal and throat swab. For the outpatient treatment, for influenza, we can use a neuraminidase inhibitor or baloxavir, preferably within 2 days of onset of symptoms. And oseltamivir is recommended for pregnancy, high-risk persons, and progressive disease, even if more than 2 days have occurred from symptom onset. Now, the time course to severe disease is much shorter for influenza compared to SARS-CoV-2. SARS-CoV-2, we often see patient deteriorating in the second week of clinical course after onset. But for influenza, usually occur within 3 to 7 days. Another problem with SARS-CoV-2 is, of course, the multi-system inflammatory disease, especially in children, and that can occur several weeks after recovery. We don't see that in influenza. Now, this is viral shedding and transmission data. This is patient with acute respiratory infections on the left upper corner. This is patient with minimal symptoms. And you can see the viral load is a lot lower for those who have polysymptomatic disease compared to those with the symptomatic disease. And the mean level of the viral load is also lower in those who have no symptom or minimal symptoms compared to those with symptomatic disease. It is about 1 to 2 log lower compared to symptomatic infection. However, the presence of influenza viral shedding in patients with influenza who have very few or no symptoms still reflects their potential for transmitting the virus to close contacts. So these are the people at greater risk for severe illness or complications. So basically, people who have chronic comorbid medical illness, they are more prone to severe disease or complications. Other people at greater risk for severe disease include pregnant women and women up to 2 weeks postpartum, children under the 59 months, especially younger than 2 years old, elderly age 65 years plus, people younger than 19 years of age but requiring long-term aspirin or salicylate, for example, those who have juvenile rheumatoid arthritis, and of course, people who are obese, also at risk for severe disease. Healthcare workers are also at high risk of acquiring influenza because of our increased exposure during patient care and risk further spread when caring for vulnerable patients. So the severe complications between the two are also quite similar. It can involve multiple systems. However, for SARS-CoV-2 coagulopathy, multi-system inflammatory syndrome and post-long COVID are more specific compared to seasonal flu. For co-infection with bacterial pneumonia, it is common in patients with influenza who require hospital admission, but quite uncommon in those who have SARS-CoV-2. And for outpatient treatment for influenza, of course, we can rely on oseltamivir or baloxavir. For inpatient treatment, of course, we would stick to oseltamivir as the main treatment. Now, for SARS-CoV-2, we know that dexamethasone is very useful in reducing mortality and improving outcome. But for treatment of influenza, steroids actually may cause harm. So this is a systematic review showing that the use of systemic corticosteroid was associated with a 3-fold increase in mortality. And even pooled subgroup analysis of adjusted estimates of mortality from 4 studies found odds ratio of 2.8. So the use of steroid has to be very careful in patients with influenza. We use it for patients who also have the concomitant acute exacerbation of asthma or COPD, but for those without airway disease, just influenza, we try not to use systemic corticosteroid. So this is another example, data from mainland China showing that high-dose corticosteroid may be associated with increased mortality and longer viral shedding. So you can see the 30-day and 60-day mortality is higher in those who receive corticosteroid. And this is mainly in those who receive high dose. So more than 150 milligrams per day of methylprednisolone, higher chance of 30-day and 60-day mortality. And when you look at the viral shedding, the high-dose steroid group also have prolonged viral shedding compared to control. So prolonged for 2 days. Whereas for those using low-dose steroid, 25 to 150 milligrams per day, there was no increase in the viral shedding. So the WHO actually published the guidelines for clinical treatment for severe influenza. So we suggest starting oseltamivir as soon as possible, and we suggest not using systemic corticosteroid unless you have a good reason, like for those who have acute exacerbation of COPD or asthma. We also suggest not to use passive immunotherapy. We need more data. And also the use of macrolide, we also require more data. So this is the more recent WHO recommendation on the components of the quadrivalent vaccine for the Southern Hemisphere. Comparing to the Northern Hemisphere, the major change is the replacement of H1N1 by the Sydney strain instead of using the Victoria strain. These are the priority groups for influenza vaccine. So healthcare workers, elderly, pregnant women, people with chronic comorbid illness, and children aged 6 to 59 months. So co-administration of COVID vaccine and influenza vaccine is also recommended these days. So this is data reviewed by the WHO. So basically, after receiving AstraZeneca or BioNTech vaccine together with the influenza vaccine, the titer, antibody titer, actually were similar compared to those who received COVID-19 vaccine alone. And there was also no increased adverse events for those who received both vaccines together. So WHO considered that co-administration of the influenza vaccine and the COVID vaccine is acceptable, but you should use contralateral limbs for injection. This is more recent data from the CDC showing that the concomitant use of COVID and influenza vaccine does increase systemic symptoms, but they are short-lived.
Professor Hugh, could you please try to wrap up a little bit now?
Sure.
Thank you. In the interest of time.
Okay. Another systematic review published recently found no safety concern or immune interference, whatever vaccines were used, and also the age of the vaccinated subjects. And for those practicing in Hong Kong, which is the gateway to the mainland of China, we also watch out for avian influenza. So H7N9, the last case was April 2019. And we also had H5N6 and H5N1. The last case occurred in mainland in November. But of course, recently, there was another case in Ecuador. So in summary, the increased influenza vaccine is expected in countries or cities without universal masking or tight social distancing measures. The viral kinetics of SARS-CoV-2 resembles that of flu. Asymptomatic and pre-symptomatic transmission can occur, and basically the symptoms are quite similar for the upper respiratory tract and systemic symptoms, but there was more rapid progression of flu to severe disease when compared to COVID-19. Multiplex PCR is useful for early differentiation between the two infections. And for treatment of flu, we recommend early treatment with NAI or baloxavir. And co-administration of flu vaccines and COVID-19 vaccines actually is considered acceptable and actually practical. So in Hong Kong, we actually have mobile vaccination teams helping our airline health professionals, ICU staff, and other nursing staff. We provide the vaccination for flu during lunchtime to improve the compliance. In Hong Kong, because of universal masking, we are not seeing major outbreaks of seasonal flu. But this universal masking policy will be removed after winter. So we expect big upsurge in influenza cases. So thank you for your kind attention.
Thank you very much, Professor David, for that very comprehensive presentation on flu versus COVID. We're living in times of both flu and COVID and how that works. That's very, very interesting. We've actually come to the end of the session, but we will take a few questions. Thank you very much to all the participants for your many questions. Most of them which have been typed in the Q&A are being answered by our experts. So you can have a look and see most of those answers, but we will have a few questions, I think, because this is so interesting. The first question I'd like to put to our panelists is from Dragana Dimitrijevic, and she says that in the light of pandemic COVID-19 and integrated influenza and SARS-CoV and RSV surveillance, what is your attitude towards COVID-19 flu AB antigen rapid test? When we know that RT-PCR is a gold standard. Would Wenqing or Josh like to take that question?
Yes, thanks very much. I'm happy to start on that. So we're talking about the different laboratory diagnostic technologies. Those RDTs will be very useful for managing patients. In certain critical important situations, the doctors need to decide which clinical paths need to take. So the RDT will be very useful. But in the surveillance, still, we would have to use PCR as well. One comment before I ask others to complement is that the more viruses you add into the diagnostics, whether it's RDT or PCR, the sensitivity will be compromised. Let me just stop here and to see if others want to talk about that. Over to you.
Thanks, Wenqing. Josh, would you like to add to that?
No, I don't have anything to add to what Wenqing said.
Professor David, would you also like to say something on? that?
RAT certainly is not as sensitive, but it is just more convenient. Like for healthcare workers going to work in high-risk area in Hong Kong, we are required to perform the rapid antigen test every second day. So I think it's just a convenient test, but certainly it's not very sensitive.
Thank you. That's the take of it's convenience, but not very sensitive. I'll ask another question from one of the questions that was put in the Q&A. It's, we're seeing more cases of human cases of animal influenza. Is this due to an actual increase in number of cases or just better surveillance? Over to Wenqing or Josh, whoever would like to take this. Wenqing?
Yeah, let me start. So as I presented, if we look at the avian influenza world, look at the animal population, the virus reassortment, the virus spill out to different species, and also the genetic diversities of evolution, they are all really unprecedented. They might be linking to the increased better surveillance, but certainly it reflects more human infection of those zoonotic virus. And this is also the reason why it's so worrisome of a next influenza pandemic, which might come very soon. But again, I hope one of my best wishes is that there's no influenza pandemic in 2023. Let me just stop here.
Thanks, Wenqing. Josh?
Thanks. Yes, the answer is yes to both. As Wenqing said, a success of the global influenza surveillance and response system has been the global network of diagnostics that has grown and is able to identify these viruses earlier and as they're circulating, protecting us all. That being said, if you look at what I showed for the United States, that's an unprecedented spread of H5 through that country. And no, that is not a surveillance artifact. That reflects the growing spread of that and other viruses that Wenqing alluded to.
Thanks, Josh. We've actually gone well past time. So would you be open to taking another question? Staying on a few more. There's one specifically for you, Josh, which is, oops. Yeah. Do you think flu-POCT testing would decrease community infections and surveillance?
Sorry, flu what testing?
POCT.
Oh,
This is from
testing. I think that the world is moving toward point of care testing, and it's up to us in influenza and other respiratory diseases to think carefully about how we leverage new technologies to improve our surveillance moving forward. When we do that, we have to do it in a way that preserves the core functions for public health of surveillance. That means that all of the data on positive and negative specimens and the test used must reside with national authorities. And the viruses, importantly, that we need to assess and analyze to improve our medical countermeasures and vaccines have to be received nationally and globally. So yes, point of care testing is a way of the future. It's up to us in GISRIS and elsewhere to think about how they're properly leveraged moving forward. I'll defer to Wenqing if she wants to add to that.
No, actually, I have nothing to add. It's a new technology we need to look into. If the point of care in the future, in the very near future, could have the comparable sensitivity or PCR, or as David said, that the use of the POC is just so convenient for clinical management, then certainly it will be widely used.
Thank you. Professor David?
No further comment.
So with that, we come to the end of our webinar today. Thank you so much for joining. There are many questions, and I'm really glad to see all these questions because it shows the level of interest in the topic. Our experts have tried to answer as many as possible. Just to let you know as well that for more information, you will get more information on flu on our website. The Global Influenza Program website has an enormous amount of information on all aspects of flu. We also have Science in 5 on influenza, which Sylvie Briand, our director, spoke in recently, and that's also on the WHO website. Our EPI-WIN website will have the presentation as well as the webinar recording and all the information you need. But I hope we will see you next time and look forward to working with you on various scientific issues for public health emergencies. Before we leave, a huge thank you to all our panelists, to Sylvie Briand, who tried very hard to connect in spite of challenges in connectivity, to Dr. Wenqing Zhang, who's also traveling but connected, to Josh Mott for his very interesting perspective on the US situation, and to Professor Hugh, all the way from Hong Kong, for staying up late for this webinar and for an excellent presentation. My thanks also to colleagues behind the scenes, Dr. Yubika Latinovic, who's sitting here right next to me, Dr. Zhang Liu, who's has provided tech support for this webinar throughout, and Ms. Aspen, Hammond, and Mr. Chris Chadwick, who've also been responding to lots of questions here. And see you next time in the next Wednesday WHO EPI-WIN webinar, and look forward to continued interaction. Thank you very much. Okay.